I hope you all enjoyed the journey through the Department of Surgical Gastroenterology. I hope you enjoyed it very much. Thank you. Now, Dr. Ramesh told me to present a memorable case during my service in medical college. I was wondering what case I should take. I was in a confused state. Dr. Balendran is there. I can't come to the front. Of course, every case for a surgeon is unforgettable because we are learning many things from the surgery. The clinical presentation, the physical finding, the surgical technique, operation in surgery, the results of surgery and the outcome of surgery and the follow-up. So we are learning many things from the surgery. So every case is memorable for a surgeon. So when I was thinking to select a case, I got a call from KIMS ER. That one patient is in our observation, wants to see him. So when I reached the ER, I saw a patient, because this is not the same slide of this inspection. Just show an introduction. This patient who came to me in 2009 for a follow-up. That picture shows there is food particles coming through a small opening in the thoracic bone. So this patient I was operated in 2000 August. So he used to come to meet me in between for the last 25 years, once in 3 or 4 years. So the entire story I will divide into 4 stages. Can you have the first stage? So this is the first stage, 2000 August. A 17-year-old boy was admitted in emergency surgical gastroenterology. The patient is from Nagarkoil. He came with an intercostal drainage tube, just draining rice and black food. He was in shock. Pulse rate was 140, BP was 70 over 60. He has anemic and tachypneic. ICD showed rice, which he has taken in the afternoon, is coming through the tube. So, tracing the history, we got that he had a congenital diaphragmatic hernia, which was not diagnosed previously. And this patient was attending the local hospital regularly for respiratory problems. And when he reached this time with the dyspnea, after an EE, they took an X-ray of the chest which showed a fluid level pneumothorax, something like that, pneumothorax or pneumothorax. They thought, and then they relieved the dyspnea, they put the ICD tube, but only rice came. Then they understood that they have clogged the stomach in the thoracic cavity. So he has referred to our department. So there was no other way to do an emergency surgery. That is the only way to save him. So we went on with the thoracolapparoscopy. I don't remember who was the PG with me at that time. It was in 2000 August. Who was at that time?
Joshi
If it is Deepak, Kurula was the other PG. You remember this case? So this was about 7 o'clock. I took him for a thoracolapparotomy emergency, and the surgical findings was a defect in the left lobe of the diaphragm, and the thoracic cavity contained the stomach, pancreas, vein, which was ischemic and gangrenous. ICD, of course, it was in the stomach. The left lung was hypoplastic. These are the sides of an orange. Probably because of the stomach, pancreas, and spleen in the thoracic cavity from birth, it didn't allow the lung to expand. That is why the lung was of the size of a very small orange. Because the rice and black food was in the thoracic cavity. It was a surgery done, total, mother remember it, right? Total gastrectomy, distal pancreatectomy, 70% distal pancreatectomy, splenectomy, and left pneumonectomy. The thoracic surgeon came to help me for the pneumonectomy. There is no point in keeping that small hypoplastic lung in the thoracic cavity. So I think it's just Yoganathan Nambudi. Yoganathan. He helped me to do the left pneumonia. And of course, the digestive continuity was made by Rohan by Isavaga University. Raisu was placed in research for the feeding. And CD was training fluid, dirty fluid, infected fluid for 1 month, then gradually reduced and stopped. And ICD was removed. And a contrast study showed oral fluid freely going into the distal jejunum. There was no leak. So the Raisu was taken as discharged. He was having a normal life. He was working in a very poor fellow. He was accompanied by his brother. He was only 1.5 years elder to him. His father died in childhood. And his mother was about 80-year-old old lady, not even able to stand straight. These two are the bystanders. I don't know how father had to bring the blood and you arranged something. He had a near normal life. In between, he used to come to meet me in the office. That's right. That was the contrast study which showed me just going freely into the research. That's right. Now the second stage, 2009, he noticed some discharge through the intercostal drainage side. And within a week, food was coming out through that organ. So when he takes food, part of it was coming out, part of it was going down. So what he did was he plugged the opening with his finger and started eating. So most of the food was going down. When he takes the finger out, the part of the food is coming out. It is not the food which was worrying him because of the excoriation and the pain in that area. That is the first film I showed. I will show it again. So of course it was a Isavaga Jejunum the condition. Because there was no obstruction, he continued to live with the limited amount of food which was going down. So because of the pain, he approached many government hospitals. A very poor man couldn't afford to come out to London frequently. And the private hospitals in Tamil Nadu he can't afford. So he went to government medical colleges, including medical colleges. I mean, government hospitals, including medical colleges in Tamil Nadu, but nobody was willing to take him for further procedure. They told him to go to the original surgeon. I don't know whether they said in good sense or bad sense. So it is the duty of the original surgeon to correct. That's right. This is how he came in 2009. I told him, when 2009 I retired from medical college in 2008. 2009 I was in KIMS. He came to KIMS. Then I explained to him, it's a private hospital. The charge will be very high, you can't afford it. So he went back. The third stage, that was in 2016. He came again into KIMS with the local people collecting some money and then maybe collected the money from the local people for the surgical expense. The contrast study was done, it showed a normal distal bowel, so an endoscopy was done, fistuloscopy, stomach. This was the endoscopy I did through the mouth as well as through the fistuloscopy. That's right. That was the fistuloscopy. Which showed esophageal intact and the blind lobe which was crystallized into the skin also, that was also normal. This is the rule of any observation or stricture or any problem if he closes it. So I took him for surgery. The anesthetist agreed to waive off the anesthetic charge. I waived off my surgical charge. And I discussed with the administration because he didn't have much money. They agreed to give some concession. So taking as a challenge, I closed the stoma because can you show that next slide? If you look closely, the stoma is under the skin. It is not, the mucosa is not projecting. So it was very difficult to mobilize the stoma. It was densely adherent to the ribs above and below. So hardly one finger goes there. So with the difficulty, I could mobilize a little bit of the vaginal length from the ribs and from the intercostal muscles. And this was only about 5 millimeter or so. I closed it, but luckily it took up and it was closed. This is when he reported after 3 months. You can see the excoriation improved and the wound was healed, and he is a happy man. Even though he is nutritionally inefficient, he is going on. He started a photo studio, married, and has a child, and have nearly normal life. The story is there. That's right. In 2025, that 1.5 to 2 months back, he was admitted in the ER, when I was called. This time he came with fever, pain in the right lower region, and dyspnea. And CT scan showed a bilateral renal calculi and perinephritis. He went into granulocytic septicemia and severe hypoxemia. Remember, he has only one lung, left lung is not there. Severe hypoxemia, and he has to be put in ventilator. Luckily, he recovered from all the problems and discharged cured. That's right. What is the plan X-ray taken this time? You can see your scoliosis, lung on right side, medial sinus is also on the right side. That's why there is no lung. That's right. CT scan showing the right lung there and the medial sinus on the right side. That's why there is only fibrous tissue and air-filled area is the eagle. This time, 2 weeks back, that is after recovering from the granulocytic septicemia, he came to visit me with his wife and child, very happy. And I must say he is reasonably healthy. The purpose of presenting this paper is not because of the intricacies of the operation or the result. 2 things I want to stress and to advise my junior young surgeons. One is, see, any surgical treatment of a patient is a team. You cannot say only one surgeon or one team is enough to treat them. You may have to get a combination of surgeons and help of the many other people to continue your treatment. In this case, I don't know why surgeons who met me with the Drusilla refused to proceed. That is one point. Second point I want to discuss is, look at his forehead. Whenever he comes, he has a Chandrakuri in his forehead. He has a temple, Murugan's temple near his house. He goes to the temple every morning and evening. Whenever he comes, he brings some prasadam to me. So it's a Chandrakuri, nothing much. And he says, Murugan will keep me in healthy condition. So what I want to stress, second point is, if the patient has a good faith in God, patient is safe, you are also safe. Thank you very much.